Go. Hey, we're right on time, and this is our 3 p.m. Sunday, April 8th, 2018 is the date. And I'm so excited to be with my dear friend and special guest, Stephen Fleiderer. And we're going to have an hour on the topic of addictions to drug, alcohol, and maybe we'll get into food as well. Stephen just is the head of founder of SF Intervention. Oh, and by the way, Lisa Kelly says hello. Phil McCormick says hello. We have 2 viewers so far, Stephen, which is exciting. But we'll probably have a good 1,000 to 2,000 before the week is over. Oh, Mark Noble just joined us. Hi, Mark. Mark Noble is a scientist from University of Rochester doing some really phenomenal research. So, Stephen, I'll let you tell us about yourself a little bit, but Stephen got his bachelor's degree from Johns Hopkins University, focusing on music, particularly clarinet, and then got his master's degree from the University of Cincinnati. And how he got into my Tuesday group started in a hot tub at a workout place, and how he then went from professional musician to a founder of SF Intervention and working with addictions is his personal story. So why don't you give us a little feel for that, and then we'll talk about some of your approach to the treatment of mild as well as severe addictions. But we've also got Jasmine from Greece. That's great. And we've got Pangiotopoulos. That sounds, yes, he's from Athens. So we got a couple. And we've got Yehuda. Oh, hi, Yehuda from Mexico City. Yehuda's the president of a college, Stephen, in Mexico City. And Great. He's a very enthusiastic cognitive and team therapist. We actually met at my workshop in Denver. He came up from Mexico City. He's originally from Israel. So let's go for the gold here, Stephen. Just what I would say has been not currently in my Tuesday group since your move up to San Francisco about a year ago to start your SF Intervention, but was in the Tuesday group for how long? Would you say 5 years or more?
Yeah, I joined the group when I was just turned 26 years old, and so that was almost 8 years ago now.
Yeah,
7 or 8 years ago. So consistently going for 5 years.
Yeah, and we've been to countless Sunday hikes together, have so many wonderful memories there. And I would say about you, Stephen, not only are you incredibly bright, but you brought a tremendous work ethic to Learning Team. I think you read my psychotherapy ebook, Tools, Not Schools of Therapy, probably 2 or 3 times from cover to cover, and it's a huge, huge book. You worked tremendously hard learning 5 secrets of effective communication, all the other resistance busting techniques, paradoxical agenda setting, and you've really done great. And now you're beginning to experience not only some real success with your intervention work, but also getting some media exposure too. Did a recent interview on NPR, and so it's just a delight to have you, Stephen.
Well, I'm really excited and honored to be here and have this awesome conversation for the next hour here. Share my experience and hopefully be of service and help others that are potentially working with addiction. And share my knowledge and experience and see what comes out of our conversation.
Yeah, and I would say just for your perspective here, we'll have a lot of therapists in our audience and a lot of general public types in our audience as well. So we'll be speaking to both of those groups. Let me just go through some of these questions that we have here. Why don't you just give us a little flavor of your own personal story, and then we'll get into your unique approach to the treatment of addictions.
So I grew up right here in Palo Alto, broadcasting here from Palo Alto right now, and grew up and great home, and I remember being really shy as a kid, and I kind of was the class clown. I wanted attention, and I acted out, and I ended up in grade school getting kind of picked on. I was one of the smaller kids and got kind of teased and bullied, and that really shaped my early experience. And all the way through high school, kind of was the butt of the joke in the group of friends I was trying to make friends with, and got teased quite a bit and bullied. And I remember when I was 15 years old, I was in the back of this my friend's dad's garage, and he offered me a beer. And I remember that like yesterday, and I was really nervous because my parents had said, "Oh, alcohol's bad. Don't drink when you're a kid." But I was also curious as a teenager, and I remember having that first drink, and it was magical for me. It just made me feel good, and I knew I wanted another one. If one's good, then two's better. And I remember, nothing bad happened that first drink, but I remember that glow, that feeling. And it was a warm glow, and I felt a part of. I felt connected. I felt a little more comfortable in my own skin, and I knew I wanted to pursue that and do that again after having that first drink experience. And so I started to pursue that kind of party lifestyle, and I felt like I was being a part of, which is a thing of wanting to feel connected. And I took that all the way through high school, and I was studying music and not really interested in other stuff in high school, but studying music. And that was kind of my forte of playing the clarinet. And I wanted to be one of the popular kids. I wanted the girls. I wanted to fit in and all that. But that just wasn't in the cards at that time. I didn't have any of these skills that I now have learned so much tremendous things from team and to offer that to others. But the drinking really helped me feel good in my own skin. And long story short, got into a music conservatory on the East Coast at Johns Hopkins. And I remember I got my first girlfriend, was really excited, and I started to, have that freedom and started partying quite a bit more. And I ended up kind of pursuing that. That was my real occupation, was let's have a good time and have a party. And I thought I deserved it as working really hard in college and, the stress of music school and practicing. And I just remember just kind of every day just feeling like I deserved a reward at the end of the day. And I was a beer drinker and drank a lot of beer, and made me feel good and get through the college experience. But I started to have consequences. And when I was my junior year of college, one of my good friends and I ended up having a pretty bad night here out in Palo Alto, and the police were involved. And I kind of stood up to this cop under the influence. And luckily, I don't know why he didn't take me to jail that night, but he didn't. And I remember waking up the next day, and I really felt this remorse and fear that if I didn't do something, my life was going to go in a bad direction. And a friend's mom had been part of a 12-step program and suggested I go check out a support meeting, and remember doing that. And that was the beginning of a transition in my life. And I ended up getting into recovery when I was a junior in college, 21, and finished the senior year of college. My world started opening up, and I realized that I didn't want to be a professional musician anymore, and ended up going to pursue my master's degree, and realized, okay, I want to help people. I've had some interesting experience here, and I want to dedicate my life to help people. And I even had this, looked up to this guy who was a professional interventionist, and thought I kind of wanted to be like him. And I'm so lucky I ended up through my journey getting to meet you and train and do the work that we've done over the years. And that's a crazy story of didn't apply to, train at Stanford directly. I ended up meeting another member of your training group at the gym, as you said, Robert Lortzen in the hot tub. And I was kind of in a bad place. I was feeling sorry for myself. I was like, I'm a loser. Why am I living at home with my parents? I should be further along by now, have my life together. And it was a really amazing conversation that changed my life. He said, leave your email at the desk. And I was teaching music lessons to kids at the time. And he said, leave the email at the desk. And he said, I want you to attend a workshop with David Burns. And I said, well, who's David Burns? And he's like, just show up and attend. And I remember walking into the workshop and all these mental health professionals and showing up. And that changed my whole life. And then coming to Stanford and learning the magic of team and really giving everything to that. I have such a passion for how much it's changed me personally, but also to really professionally be able to help people who are struggling with all kinds of various things, from exactly what team, anxiety, depression, habits, addictions, and taken that and then turned it into what I now do at SF Intervention.
And tell us about what you do at SF Intervention and how it might differ from some of the other treatments out there for addictions, because I know we've talked an awful lot on hikes even before you had formed your company, when it was just a dream. I remember, specific places, trails that we were going down, and you were saying, I'd really just like to be able to help people. At one point you were hoping to be able to connect with teenagers and high schoolers, and now it's a reality. And you've gotten both the team training at Stanford. And I might say you're one of the trainers, one of the small group trainers in our Tuesday group. You kind of evolved from a beginner to an expert who was really helping to teach others in the training group. But now you have your own company. Tell us about what you do at SF Intervention and how you work with people, because I think there's a spectrum between the mild people with the milder addictions who could come to you voluntarily for maybe normal, as I understand it, outpatient types of weekly sessions, all the way to people who are referred, say, by parents and teenagers or hardcore addicts who are living in the gutter and on the verge of death and need to something to happen, like today, or death is going to be imminent. And I know that you do a lot of work with families too, and I've been intrigued at the enabling role that you see almost 100% of the time when you have someone with a severe addiction problem. There's almost always a so-called loving parent or family member who's kind of enabling that person, and that enabling has got to stop. And what a scary thing that is for the parent to say no to some child who looks like they're, and who is in reality on the verge of a tremendous catastrophe, which could include death. Tell us a little about what you do and how you do it, and what are some of the keys to success, and what it feels like to fail, because I know that there's a lot of failure involved in the work you do, as well as the amazing successes.
Mm-hmm. So there's a lot to say based on this question. So I do a lot of different things at SF Intervention. I break it down on a high level as coaching people and helping coach people in various directions of moving forward through various issues being impacted by substance use and other co-occurring issues. And then formal interventions, which is designed to, I always get the question, what is your success rate? And I kind of ask the question, what is your definition of success? And an intervention is simply designed to change the status quo. It's not designed necessarily to, which I always want the outcome of someone to step into recovery, change their life and heal, and not self-destruct. I want the same thing, but an intervention is simply an invitation to change the status quo. And that's not just for the individual who's really potentially suffering catastrophic consequences. It's for the whole family and the whole system impacted by that. So there's two types of interventions that I do. One's an invitational model, where there's no secrets. It's a meeting, a discussion, uses a lot of the 5 secrets, as well as the gentle ultimatum technique and the fallback position. And we can go into more detail about that. And as well as what the traditional original intervention model, which is called the Johnson intervention, which is what you might see on the television show of a more confrontational, where it's a real life or death situation and the person of
Well, just for our listeners, we've been having a little transmission issue here with Stephen. I think Stephen will have to reset his video there. I think he's doing that right now. We're not quite sure what the cause of that is. Oh, now you're back.
I'm back.
Good. Yeah. So as you were saying.
So as I was, I'm sorry it cut out. That might happen again with this connection. I apologize that this tech issue is going on. But I was saying that there's two types of intervention: the invitational model, where it's a conversation and developing a plan for everybody to move forward, and the confrontational classic intervention, which is a firmer message of a person needs to be in a higher level of care to save their life, and they might not want to be there, but it's a last attempt to get them to the right place. And the third major thing I do at SF Intervention is help people get into the right type of support, whether that's a mutual support group in the community, to the right team therapist or therapist in the community to work on an outpatient basis, or to be in a residential level of care at somewhere all over the country, depending on the person's needs. So those are the three major things that I'm doing. I also
bring one of those to life for us, because so far it's just words. Give us a picture of how you might be intervening with some family whose son is 17 and injecting heroin, or I know you've been into some really severe situations, and we can't talk about specific cases to protect confidentiality, but I'm sure you can talk about these things in general terms, and how you would intervene with the person, how you would intervene with the mother, with the father. What are the tough messages that people have to hear that they don't want to hear? Bring a little of that to life, because I know it's very difficult work, and it's very dramatic work.
Sure. So with someone that's severe, more on the severe side of a substance use disorder, and it's important for people to understand that the term addict or alcoholic, a pejorative term of you're either an addict or an alcoholic or not, that's not actually accurate on the spectrum of from 0 to 100 of the severity of someone's substance use. But in a situation where someone's severely addicted to what we call polysubstances at times, multiple substances, and using them at a level that could mean imminent death, an intervention is designed to help the family to share a loving message of concern and also implement the limits of what they're willing to change. And for example, and it's one of the hardest things to walk people through, is that if someone wasn't willing to get the medical treatment that they need, that they would no longer feel comfortable or good and feel guilty providing them a shelter to use their substances, or providing them money or resources, and implementing these consequences that are just hard, really difficult to put in. And when that message is brought with love and concern, I often do see people finally realize, that the addict or a person with a substance use disorder realize that the game is over. I'm no longer going to get the money or the rent or a place to live or the support I've been dependent on for so many years. And now I have a choice to potentially live on the streets or to go to a treatment facility. And faced with that decision, not every time has the person chosen to go to the treatment facility. Some have, in fact, chosen the difficult path of being on the streets for a while, and then they've eventually ended up at a facility. However, the strength of the family to finally say, we're done playing this game. I can't play this game anymore. That's killing you. And as you use the term enabling, that's one of the hardest things for a loved one to say no, to take a stand.
What percentage of the time, Stephen, when you're working on the severe end of the spectrum of addiction, what percentage of the time is there a family that's enabling the addiction by giving money, by giving shelter, by really paving the way for the person to have and maintain their addiction? How common is that?
100%.
100%. And then how much resistance do the family members put up to what you're telling them they have to do? Because if this is my son, and you're saying I have to tell him you can't live here anymore, we're not going to give you any money. You've got to get into treatment, and if you don't get into treatment, then everything we're turning off the spigot. Because as a father, I might be afraid that my teenager is going to die, that I'm going to say something that will kill my child. Is this too extreme, what I'm saying?
No, it's very common, and I say this from the beginning. First call that I have is the anxiety, the worry, the concern of going into a conversation like this is very real and usually very high. The stress, and I also do see, a lot of resistance, but it varies. Some people, and this is why I provide coaching instead of some people that aren't ready to go into a formal intervention. They want to do some coaching to get some more information to potentially move in that direction. But I have seen some situations. I'll give an example right now is waiting for the person to change. I'm going to wait and see what happens. And this person ended up getting into a severe accident under the influence and ended up in a coma. And that was heartbreaking. And then there are people that I work with that are ready. They've had enough. They've had enough pain. They've been dragged through the mud, so to speak, by their person's destructive behavior. And they don't want to put down this ultimatum or gentle ultimatum of you either get help or you can't live here anymore, for example. And it's not always that extreme, by the way. I had a person go to treatment when they threatened to take their computer and take the door off their room, said you're going to not have the door in your room. And the person ended up going to treatment that day. So the consequences don't always have to be you're out on the streets. So that's not always but for some situations where it has gone quite bad, those are the last end resorts. And some people, when they call, they've been through enough pain themselves. They're ready to do that. But for the ones that aren't, they do a lot of work with their anxiety and guilt, feeling guilty that they've caused this problem is another common thing I see. So it varies.
There's an interesting analogy, what you call the technique that we've created in team called the gentle ultimatum, and that's one of the techniques for dealing with what we call process resistance. And process resistance means that there's something the patient is going to have to do that he or she won't want to do in order to recover from depression or an anxiety disorder, a relationship problem, or a habit or addiction. And a lot of therapists are afraid to issue the gentle ultimatum. For example, because they want to be nice, they want to kind of love the patient into recovery. And yet, if you don't issue the gentle ultimatum, the prognosis for recovery is very poor. So if someone's coming to me for the treatment of depression, the gentle ultimatum would be something along the lines, hey, I've got wonderful tools to work with you, and I'm very confident, just about certain, that if we work together, I can show you how to get back to joy and self-esteem, and probably pretty quickly. But one thing you're going to have to do, and it's not negotiable, is you're going to have to do daily written psychotherapy homework. And if you want a form of treatment where you just come and talk, and you don't have to do the homework, I'm not the therapist you're looking for, because I've never had a patient who recovered from depression who refused to do the psychotherapy homework. And this is usually very effective. 95% of the time or more, the patient says, no, you're the one I want to work with. But it was so hard for me to develop that technique and to build up the courage to use it, because I had the same narcissistic codependency that the parents of addicts have, thinking I'm going to be so nice, I'm going to love my child, or this person in our family who's addicted, and then they're going to turn it around. And the parent has to be able to make that same transition that therapists have to make, is to issue that gentle ultimatum. Is that fair, the way I put it?
Well, that hits it on the head. And so in general, that's what I would sum up what an intervention is, at least in how I perform it, is helping coach people to do a gentle ultimatum, and walking through that process. Which is, and I've had the same issue myself, and that's where I could sit here with confidence. I'm laughing because I've tried to save people, and I thought my brilliance, and I'm Stephen, and I've been in recovery, and I know this stuff, and I just need to read some expert stuff and share the right thing or in the right way, and they're going to get it. The light bulb's going to go off, and then they're going to realize, wow, Stephen is brilliant, and I'm going to just change my ways. And that feeling is really seductive and powerful. And it's also just, if I love them enough, if I show them with my tears, or I beg them, or I get angry, or I show my passion, that'll motivate them. And I've tried all these strategies myself, and it's really cuts to the core, of just how much I care and love people. And I've fallen into these traps in the work as well of really wanting a person, the positive outcome. And I've, learned every time, never one time has it worked to try to really push someone against their will to do something.
Yeah, the same method is been shown to have about a 50% cure rate for anorexia nervosa, which you could view as another addiction, the addiction to thinness. And the only method that I've heard that really has a reasonably high success rate is called the Maudsley model, but I call it the coercive model. Is because that's really what it is, and the way you do it, it's just like the same thing that you're doing with the families of addicts. Is you get the mother and father to sit down on either side of the child with anorexia, and you force the child to eat, and the mother and father have to support each other as a firm team and not give in. And if you have to sit there 6 hours to get the child to eat, then you sit there 6 hours. The therapist, I guess, can sit there with them for 6 hours too. But that is the thing that works, and the child will whine and complain and scream and protest and try to break the parents down and to get one of them to give in and be real nice. But if they stick with that in a firm but loving way, no, you're going to eat this, and 1 pea is not enough and 1 grain of rice is not enough. You're going to eat a full model until the child finally gives in and complies, and that approach does have a reasonable success rate. And the problem is that with anorexia nervosa, a certain percentage of them actually die from anorexia. So the coercive treatment is mandatory, indicated, and life-saving, just the same as in your work. To bring us in a different direction, I know one of the things that you're really powerful at is empathy and the 5 secrets of effective communication. One of the things that we train therapists in my Tuesday groups at Stanford, so therapists will increase their therapy skills usually very dramatically if they practice these exercises we've developed, and you're one of the ones who developed tremendous empathy skills. But one thing I just thought was interesting was when you were first coming to group and coming to the Sunday hikes and talking about how you'd love to do intervention work. I mean, you had been for years in AA, or 12-step group, whatever you want to call it. And I think you, like me, feel that there's a tremendous place for 12-step programs, that getting that free, unlimited support from the community is just a fantastic thing. A blessing that we have. And there's all kinds of 12-step programs now. It's not only AA, but recovery, or smart recovery, and all these support groups. And I think you believe too that they're an important part of the treatment of the more severe addictions, but it has limits. We all have flaws and shortcomings, and one of the problems you used to talk about with AA, and I don't mean to criticize AA, I praise be to God for AA, it's great, but you used to talk about some of the shortcomings with AA too, and how you've tried to correct them in your own work. Particularly, you said that one of the problems when people go to AA, people start talking at them and don't empathize. The people in AA don't know how to listen and to hear what the people are saying. They have these spiels that kind of throw out the patients, and it can be for many people a kind of a turnoff, because we all like to be listened to and heard. Even if we're going to get some kind of gentle ultimatum, we want it to come from somebody who's hearing us and seeing the world through our eyes. Can you talk about how you've used empathy in your own work, as well as other ways that your own treatment of addictions might differ from some of the other kinds of things that are being promoted these days for the treatment of addictions?
Yeah, one of the there's so much to talk about in regards to mutual support groups, and the difference between a someone that's trained professionally to listen and empathize and provide, as in the paradoxical agenda setting, will help with motivation and resistance to change. I think I'll start about the positive aspects of a 12-step or any support group. For me, and I can make the analogy to music, that in order, and this is also with team, is in order to get really good, I needed to practice. It was like the 5 secrets is like learning a scale, a music scale, and I had to practice that pretty much daily to get better at listening. And I realized after working with you that I sucked at listening. I just was so waiting to say something brilliant from my frame of reference that I wasn't even hearing the.
Oh, you're out again, so you need to reboot us again, and I'll see if I can babble a little until you reappear on the screen. But
how's that?
Oh yeah, you came right back. Yep, here you are again.
All right, something's going on in this thing, but whatever, we're going to roll with it. So, what I was saying is I learned how much after working with you was humbling, how I didn't really know how to listen to people. I was just waiting to respond. I wasn't actually seeing how they were experiencing any moment from their perspective. And it wasn't until, and this is one of this is a just general issue with a lot of human beings, is they don't have the capacity to really be present and listen and understand where that person's coming from. And the whole goal of working in an intervention is training people to empathize, to get the person's perspective. Why are they abusing substances? There's got to be, why are they doing it? And the criticism I would say is a lot of perspectives in the general public, as well in the theory, the disease concept of addiction, is because, or even a further step is they're weak. They have bad will. They don't have good willpower. They're just a bad person, and they just want to do that, rather than really getting the reasons at why someone would turn to substances and party and do these behaviors. And so part of the work is to help people to, for maybe the first time ever, really connect with their loved one in a real way of why are they doing this, and understand that before going into any of their personal feelings or reactions or what they even want. And that's a revolutionary change. And I'm not seeing this in a lot of treatment programs across the country going on, but also, and I can't blame, an organization or institution, because they haven't had the opportunity to really train and learn these skills. And it comes back to, it's a practice. It's a skill. Listening, I've learned, it doesn't just something like this idea of someone's just a good listener. I don't buy into that. I've had to really work and practice. And
most therapists fancy that they're wonderfully empathic and good listeners, and a lot of the people listening to our program say, "Oh, I'm a good listener," but we measure empathy at the end of every therapy session, and we also practice this in small group exercises in the Tuesday group, and you find out really rapidly that your empathy skills are really, really quite poor, but there are some things you can do to beef them up. Now, we have a few listener people here that I want to just weave them in. First of all, Gladys Villa, V-I-L-L-A, Villa, says, "Hi, David and Stephen." So, hi, Gladys, and many others are saying that. One of my really favorite people from Boston, Rob Gregorio, has been to many of my workshops, and he's a business person. He's a layperson, but with an intense interest in the psychological themes, and does a lot of work with support groups and things to kind of guide people. But Rob said, "I heard the same thing about AA, not always empathic," which is kind of neat. And then he raised a question for you, Stephen. He says, "I consider myself lucky that I don't have a lot of firsthand experience on this topic of addictions, but isn't the risk of the addict dying or turning to prostitution when being cut off from the family real? So does it come down to playing the percentages? Is the status quo worse than cutting the addict off?" And that's such a key question. Why don't you address that?
So it's hard, as I say all the time, I'm not a psychic. There's a lot of psychics in San Francisco that someone could go to and get a reading about what's going to happen in the future, and especially if I do an intervention, what's the prediction of what's going to happen next? And it can go in a different directions, and that is a real concern that people do that, turn to prostitution. And also we see overdose, we see death, we see suicidal behaviors. There's a lot of issues that go on with severe addiction. And this is, again, a good segue into the decision-making form. And what I say about an intervention is it's not just, and it's something I have to put that message very clear, an intervention is not just about one person. It's about multiple people, because multiple people are being impacted by this and are suffering. And the question is and it's a decision, is what are the risks and benefits of moving forward with expressing in a crafting and expressing in a skillful way one's feelings and what their desires are for the person of concern and in the situation. And then putting the accountability, and this is an important thing, is the accountability or personal responsibility, which I like that in your book, Feeling Good Together, you talk about personal responsibility. And I see for recovery, for someone to really get into recovery, they need to learn about personal responsibility for their decisions. It doesn't mean, and this is where the empathy comes in, it doesn't mean they're a bad person, that they're addicted or that they're doing certain things, but they are, in fact, responsible for the consequences of their choices. Now, with an intervention, the family or coworkers are paying the price of a person's destructive decisions. And so when I'm on the phone with a concerned other, I ask them, is that something you want to change? And there are, with anything in life, there's positive consequences and negative consequences. And it's true. One of the negative consequences is a person could choose to deteriorate further. They could choose to pursue their addictive lifestyle to the gates of insanity or death, and that does happen. However, when we talk about intervention, the goal of it is to raise the bottom. There's a term, rock bottom. I don't buy into rock bottom, because some people's rock bottom is, in fact, losing their life. And what we talk about with intervention is raising the bottom, giving the family, the concerned others, an opportunity to express their concerns, worries, fears, and desires and hopes, and give that person an invitation to change their life. And if they make the choice, which I remember a case, the person said, I'm going to be homeless. This is all your fault. How could you do this to me? And that person needed to understand that they were, in fact, choosing. They had a choice to stay in a hotel room that night. They had a choice to go to an outpatient program that night. They had a choice to get on the plane with me and go to a residential program that night. And they chose to go watch football and be homeless. And,
okay, that's cool. That's fantastic what you're saying. Now, I want to give a little more feedback from folks. I have another controversial question here now that we got you on an awesome roll, Stephen. Susan from Albany says, hi, so grateful for these videos. Hillary says, hi, David and Stephen, so glad to be here listening to your wonderful insights. Phil McCormick says, awesome. Good for you to have the insight to change, Stephen. Sylvia Stewart, I'm here too. And Ran Smith, hi, David and Stephen and everybody. And Zane is here, and Bernie is here. Hi, Zane. Maybe we should get Zane to get you and Daisy on one of these Sunday podcasts at some point when you guys want to do that. That just popped into my brain just now, but that could be really a fun Sunday podcast. Zane is in the Tuesday group and was also on one of the recent Feeling Good podcasts with his wonderful wife, Daisy, and did something just mind-blowing. But you mentioned getting people into these treatment centers. Now, I see these things on TV. You go to this fabulous place and it's going to cost $80,000 a month, and you're going to have spas and people massaging you, and you're going to be on the cliffs overlooking the Pacific Ocean. And I sometimes ask myself, and I tend to be a bit of a cynic, are these things have a main focus on treatment or on making money? And is this a kind of a commercial for dollar thing? How many of the people who go to these expensive places, are drug free in a year or two after discharge? And are there other less costly alternatives? Because we can't be we've got this tremendous addiction going on in the United States, and we can't be sending people to these $50,000, $60,000 a month places. What do you? I know you're very dutiful, Stephen, but have you also wondered about mixed motivations with some of these high-powered commercial treatment centers? I don't mean to throw stones at anyone, but just raise questions that have occurred to me and probably everyone who's seen those ads on TV.
So it's an easy question to answer. There are, like any field, there are great people. There are wonderful people I have tremendous respect for and feel a confidence sending to different programs. And there are also some bad apples that are in the industry to take advantage of people's vulnerability and exploit people in regards to a financial gain. The need for residential treatment for some people is the appropriate place for them to get in the game, so to speak, to stabilize. I like the analogy of, in order to learn how to play tennis, if you go to camp and you're doing it every day for the first, 30 to 90 days, you're going to come out a lot further along. And with addiction, and this is a recommendation for changing any habit, really giving, every day for the first 90 days, everything, and having a safe space to do that really has saved people's lives to start the foundation of their recovery. But that's not enough. Many people, when they leave, end up falling off the wagon, so to speak, or relapsing. And this is a long-term process. Some people don't need to stabilize in a higher level of care. Some people are more severe and do need that. And what I say is that I always like what's called the stepped care approach. So we could start at a lower level, depending on the severity. And if that's not working, not a problem. It's just an indication that something of more intensive is needed, and also a real look at the motivation to change as well. So yes, there are fancy spas, and I like going and getting a spa treatment. But that's not curative. The word cure, I'd be wary of that in general. There's no cure, magic bullet. However, I know many people that they credit going to residential treatment as their first stop in order to get in the game. And then, of course, that's not the end of the journey.
Yeah, that's one of the things, I think the great things about AA. I mean, whenever I've treated people with addictions as an outpatient psychiatrist, if it was severe, I've always said, if you want me to work with you, you have to go to AA. 7 days a week initially, maybe more than 7 times a week initially. I can give you something that AA can never give you. They don't have any of my specialized skills, but they can give you tons of stuff that I can't possibly give you. So that's my phone ringing. I just ignore it. Now, Julianne Lindeen has a good question for you here, Stephen. I'm interested in hearing your views on the opiate crisis. Are you a proponent on the step-down drugs? Now, I don't even know what the step-down drugs are, so I'll leave that to your expertise, Stephen.
So there's many, psychiatrists that I refer to or consult with. There's one that's actually doing a fellowship at Vanderbilt right now on the opiate crisis and talking about the prescription medications, buprenorphine, naloxone, naltrexone. There's many different, and then just came out recently, and I'm not familiar with the exact name of the pharmaceutical drug to prevent if someone was overdosing. But it is a huge problem that, they're working.
What are step down drugs? Is that you switch from heroin to some other opiate, and then it's supposed to be easier to get off of that one?
Correct. There's a drug called Vivitrol. There's buprenorphine, Suboxone. And what's been known, a lot of people might know, is methadone. There's been methadone clinics, which is that doesn't produce the euphoric effects of an opiate. Like heroin, taking heroin and injecting it, but it will give the person, that they don't go into the painful withdrawal symptoms. And for a lot of people, they've been put on these medications, Suboxone or methadone or a combination, and that's managed by, someone that's licensed. And I make very clear that I'm not a licensed practitioner to prescribe these medications, but the trained medical professionals to administer those drugs and prescribe them it can be life-saving. It's what we call medical assisted treatment. And so one dangerous thing, and a lot of people in the general public say, like, you got to quit cold turkey. And I want to say this on this broadcast, I said this on the NPR interview, is especially with alcohol withdrawal, if someone were to attempt and they were severe and try to quit cold turkey, they might go into a seizure and die of withdrawal. So it's important, and this is another real reason for being under the care of a medical team of professionals, or if they are a severe opiate addict, to make sure they're getting prescribed by a licensed addiction medicine trained doctor, to get the right medication to, get through their initial phases of recovery. So I will say for me that every case is different, and I'm agnostic. Some people can go and get detoxed from an opiate and then not have to ever return to any type of, assisted medication. And others, their case is different, and they do need that. And so what my blessing, or what I say, is whatever works, and consulting with the right team of professionals, and being under the care of that. So, yes. And there's another thing I'll say as well, is what we call monitoring. Drug monitoring is some people, it's like the babysitting, and people that are addicted hate this, and I hated it too. Is how I don't want a case manager to manage my life. I don't want someone telling me I have to do a drug test. But this is the accountability for a lot of people that they need in early recovery to make it to those initial milestones to change their life.
To tell us some, and if any of you want to go in type in other questions, we're open to that. We got something here. Let me just see. Working Terry Rope, it looks like, working primary care. I see many clients who need help with addiction, and there's a dearth of addiction specialists in our state. Important to work partner with our mental health colleagues to address these difficult issues. Yes, that makes sense to use. So what you seem to be saying, Stephen, is to use all the tools at our disposal, and there isn't any one pure one size fits all. Tell us more. Suppose somebody comes to you as an outpatient and doesn't need to go into a treatment facility, but is struggling with overeating or drinking too much, or maybe addicted to like Xanax or something like that. How I mean, it's probably too general of a question, but how would your treatment approach work?
Well, before answering that, I want to put two important things out there. One, last year, the Surgeon General wrote a milestone report, the Surgeon General, about the addiction crisis, and that can be found by Googling Surgeon General Report, Addiction Crisis. It's all about, and they talk about many pathways to recovery, and this addresses multiple chapters to inform people that the addiction crisis, and this is as I think as monumental as what we had when it came out about tobacco use. Great.
But we don't want to go read a report online. We want to find out what Stephen does. Tell us about your own unique approach, because they didn't include that in the Surgeon General's report, and they should have. So
absolutely.
Tell us.
I'm happy to do that. So in my approach, if someone came and they were coming to me specifically concerned about their own substance use, and they were addicted to potentially a few substances, or concerned about that? Is that what we're
on an outpatient? Okay. How have you kind of borrowed from team therapy and other treatments to create your own cool and quite effective brand of therapy? So tell us about Stephen.
Absolutely. So I'm going to talk about myself. And I can do that. So the first thing I do is exactly what we would do in team, is ask them, kind of get a general idea of what they're looking for. What is it that they want to change, and why are they seeking anything from me at this time, and what's going on, and connecting with them and empathizing with them and letting them know about the different tools that I provide, like the habit and addiction log and the devil's advocate technique, and of course the paradoxical agenda setting, the motivation to change techniques. But the first step is to figure out, is there something that they're wanting my help with, and what type of help do they want? And if they are in fact looking to change, really asking those questions on the front end about what is the outcome they're looking for outcome resistance, and what are they going to need to do in order to change that.
Now, do you use some of the paradoxical techniques that we've developed? Like in one of my workshops, you may have heard me talk about Benny, this heroin dealer and drug user and violent fellow, and kind of challenging me and defying me, kind of a violent fellow from the neighborhood where our hospital was in Philadelphia. And what was really helpful for him was making a list of all the reasons to continue doing what he was doing, and rather than try to help him. And when I listed all the benefits of saying I'm a hopeless case, and well, then you can keep using drugs and dealing drugs, you have all this money and all this prestige, you can be violent and blah, blah, blah. And at the end I said, well, Benny, you asked for my help to change your negative thoughts and to change what's going on, but it seems to me like you've got a good thing going. And then he said, Doc, you read me like a book. And then he talked about a traumatic event in childhood and began sobbing and really became vulnerable. And I think that my hunch is that most therapists, like what you've seen in AA, is when someone comes, they start selling things to the patient and pushing things on the patient, and sometimes to look at all the reasons not to change, all the good reasons to keep this addictions, and all the good reasons not to give it up. I call that the double paradox. And I'm wondering if where you become the voice of the patient's resistance rather than trying to sell the patient on something. And I'm wondering if you found that any of those techniques play a role in the kind of work that you do.
I use it every day. I use it, almost in every session, and I use it even for people as a kind of a check-in for people that have made the gains, to kind of push them and say, you just had this milestone happen. That would be a real good reason to go and, have a party, and encourage that. And then it's very powerful. And exactly, I use all the good reasons to keep on the status quo of doing what you're doing, while also adding what the I feel statements from the 5 secrets of, when there are situations I do feel concerned, I don't beat around the bush. I do let people know if I feel worried or concerned about their welfare, if they are abusing substances on a level. But of course, the paradoxical agenda setting has been a game changer of not having to get into a power struggle or sell someone on changing, and getting them into the driver's seat of their life and seeing if they want those things.
Let me ask you this question, Stephen. I know you've visited umpteen million treatment centers and interacted with all kinds of people in the addiction field, and you've been to umpteen million AA meetings, and you've sat in on smart recovery meetings. How many addiction therapists have you seen, whether they're formally trained like yourself, a certified California addiction counselor, or just lay people in AA? How many of them have you seen who are really skillful at using like team empathy techniques and paradoxical agenda setting techniques and looking at all the reasons not to change? How common is that in the addictions field? How many can we count?
I'm drawing a blank right now. I don't know.
Are you the only one in the United States
that has this specific
using these new techniques?
Yes, that I'm aware of. Especially, at least within this domain. Yeah, which is kind of taken.
Okay, now we have a question from Adara Leia. Now we're getting to the gritty of our interview here. We only have a couple of minutes left, but Adara Leia, does paradoxical agenda setting always work, or is it better to look at the negative side of the addiction for some people? Great question. And Stephen will now give us a brilliant and correct answer.
So in the terms of always work, in terms of addressing these are not made up. These are the real barriers that need to be pushed through in order to get to the other side of the shore, so to speak. It works every time. Does it get the result of the person giving up or abstaining or really making those goals? No. But the person can realize that, I don't want to change today. I'm in this state of ambivalence. I kind of want to kind of experiment still and pay the price of overeating or, restricting my eating or binge drinking, and I'm fine with it as today. And that's actually a gift to give them. But when they do choose to walk out that door, I make sure to share my real concern for their well-being and the real risks of their decision. But in terms of bringing...
And I think that's why it's hard to be a great therapist, because you have to integrate opposites simultaneously. Mm-hmm. Seeing the world through the patient's eyes and letting them know that you can see all the good reasons not to change, mm-hmm. while at the same time dangling the carrot, showing compassion and showing concern with what the real danger signs are. Mm-hmm. I think people are often going into therapy or addiction counseling, they're looking for formulas they can throw out at people. And I think that's true in all of therapy as well. It's hard to become a really great therapist because it requires thinking on many different levels simultaneously and bringing genuineness to people while at the same time, and vulnerability while at the same time using powerful techniques in a skillful way. Adara asks you, Stephen, do you have people addicted to food? Is that reasonable to think of overeating as a kind of addiction?
Absolutely. What we would call process addictions of just eating, gambling, TV, shopping, spending money, internet. There's treatment centers that have opened up for internet addiction. And, absolutely, over people that they don't want to, on some level, really want to be doing those behaviors and overeating. At the same time, they get the pleasure and the reward from the food. And absolutely, I would conceptualize that as a habit or an addiction. Yes.
Yeah, I love what you're saying. I totally agree. I have a question here, and we may have a little controversy around it, which is totally cool. But why do we have all of this upsurge in addictions? Like I said, I saw on TV, and I suspect it's correct, 40% of Americans are overweight. Mm-hmm. And we have just massive substance abuse and alcohol abuse. What is the cause of it? And the popular view of it is that people go to addictions to treat themselves for their depression, their anxiety, their loneliness. We're overeating to fill that hole in our heart. You hear things like that in the media all the time, and there's certainly some evidence for that. For example, I think 50% of people who have significant shyness have a problem with alcohol abuse or benzodiazepine abuse, because they are in fact medicating themselves in social situations to try to become more relaxed. But you're aware of the study I did in the Stanford inpatient unit. It was not a formal published study. It was just some data that I collected while doing another study that was published. But I had data on 178 people admitted to the Stanford psychiatric unit, and I had data on every conceivable human addiction: gambling, every form of overeating, every type of alcohol and drug abuse, measured quantitatively with really good, accurate scales. And then I also had data on about 50 psychiatric diagnoses measured continuously with highly accurate scales, like exactly how much depression they had, how much anxiety they had, how much loneliness they had, all of this kind of thing. And then I was able to say, what do these emotional upsets, what role do they play in habits and addictions? And I was surprised that there were no correlations between any negative emotions and any addiction, really, of significance. And the only thing that seemed to correlate with addictions was the desire to get high. I have a little urges to use scale. I don't know if you've actually used it in your work, Stephen, but that was massively correlated with any kind of addictions. And the conclusion my study showed is that people, we have addictions because we like to get high. You didn't have the obesity epidemic 150 years ago because people didn't have all this fabulous food available and the money to buy it. And there weren't Burger Kings on every corner and McDonald's and Filet-O-Fish, French fries, we're so tempted because we want to get high. And that was really the only thing that I saw that seemed to play any meaningful role in addictions. And if this is true, what it would mean is that if you have somebody who's depressed and drinking, and you treat their depression successfully, which you may or may not be able to do, but you make them happy, they'll be happy in drinking. You know, they won't stop drinking just because their depression goes away. But you've also emphasized, Stephen, that people with addictions, when you treat addictions, you're treating the whole person, because they will have problems in their intimate relationships, they will have depression, anxiety disorders, and so forth. So what's your take on that? You know, what causes addictions? Do we know?
I say this all the time. I think it's complex. I do think addiction is complex, and we've covered a lot of ground talking about everything from medication-assisted treatment to the right type of level of treatment and all the other things that go in. But I do see that the desire, that instant reward, the pleasure, the solution for a lot of people, like you said, might be the best thing they got going, and giving that up just is really threatening. But I also do see that there's other co-occurring on a human level, other things going on that could feed off of each other. But I do see, and well, just if we isolate it down the core, people do these things because they're getting some type of reward from it, and I get that. I mean,
absolutely.
But I like to be, and I want to be the drug dealer that's giving team out, that I'm hustling the team to get high, and so that if they want to get sucked into something that does, you know, have a cumulative effect to change your life, that's something worth pursuing.
Right.
And that's kind of that dangle, that carrot. But it's true that it's possible to get rid of this bad stuff and, you know, offer these powerful tools.
So at any rate, Stephen, you're treating the person and not the addiction or the disorder, and you have tremendous tools available. And if any of our listeners need your tools or have family members who need your tools, you're founder of SF Intervention. And if you go to Google and just Google SF Intervention, you'll come to your, what I was going to tell you, it's really a beautiful website that you've got there. And that would be their best route for making contact with you if they had that interest?
Yeah, there's a lot of information on the resources page and education, things that we didn't get to go in today. It's at sfintervention.com. And then if they'd want to contact, there's a contact form and also a phone number to leave a voicemail. Yep.
Great. Well, thank you so much, Stephen. It was a joy seeing you today. I haven't seen you as often since you've been up in San Francisco, so this is a good way to hang out. And thank all of you who joined us today. Have a terrific week. Next week, I'll be back with the David and Jill Show with our special guest, Mike Christiansen. We don't know the topic yet, but we're going to cook up something really sexy and cool and fun for all of you. And then tomorrow, some of you may wish to catch my Feeling Good podcasts, which come out every Monday, and you can find that on my website, feelinggood.com. So goodbye, Lisa. Goodbye, everybody, and have a great week. Bye-bye.